It says Part 4 of Chapter 12, Diseases and Conditions of the Reproductive System. And pregnancy is not a disease. Pregnancy is a condition. I can't even say it's an abnormal condition. It's just a condition of the female. Now, certainly, when we look at pregnancy, I'm going to talk a little bit about normal pregnancy, but I don't spend too much time talking about normal anything, which kind of makes it difficult for people who may be pregnant right now to listen to all these conditions, because I'm going to talk about the worst, the things that the person may seek treatment for. And most pregnancies are going to go just completely normal, and the person's not going to have any of these problems, but it's my job to teach about the worst things that can happen here. The first thing about pregnancy is that the person must have good prenatal care. The most important factor in pregnancy is good prenatal care, and that's good care, physician supervision, even before the person gets pregnant. If they know that they are planning to get pregnant, they should go to the doctor and talk to the doctor about vitamins that they should take and precautions they should take. And certainly as soon as a person suspects they may be pregnant, they need to go to the doctor for the monitoring and checks that they should receive. They should be checked regularly for weight gain, for their blood pressure, to have sonograms performed. There's a description in your book of some prenatal diagnostic tests like amniocentesis. Now, amniocentesis is not usually done on pregnancies unless the person has some family history of chromosomal abnormalities, or unless the pregnant person is over the age of 35. Because over the age of 35, the person's more likely to have these chromosomal abnormalities that could be picked up by amniocentesis or detected by amniocentesis. The chronic villus sampling, again, that's a biopsy procedure that the person would have to have good reason, the doctor would have to have good reason to suspect some serious problem going on to do the chorionic villus sampling. It is really common, though, that the women will have sonograms performed, and sonograms will be performed numerous times during the pregnancy, and it's just amazing to see the sonograms now and the results of those pictures that can show the baby's little fingers and toes and so many parts there. So you can see a real good picture in your book of a 28-week 3D sonogram there. I want to tell you about how reproductive history is documented in medical records. You know that I teach health information technology. I teach about documentation in records, and a very common way of documenting the number of pregnancies and the number of deliveries is by gravida and para. Gravida represents the number of pregnancies. Para represents the number of deliveries. A person could be gravida 1, para 0, if they were pregnant for the first time and have not yet delivered a baby. A person could be gravida 1, para 1, pregnant once, delivered once. A person could be gravida 1, para 2. What's going on there? Gravida 1, para 2. That's 1 pregnancy and 2 deliveries. That would be delivery of twins. So important as far as reading the documentation in the chart is realizing that the gravida and para mean number of deliveries and number of pregnancies. Okay, conditions related to pregnancy. Almost everyone that is pregnant has some morning sickness. Morning sickness is completely normal. It's nausea and vomiting associated with pregnancy. About 80% of the women are going to have some degree of morning sickness. Usually resolves in 12 to 16 weeks. Sometimes it will persist longer than that. If the nausea and vomiting are severe enough to cause weight loss or metabolic imbalance, then it's referred to as hyperemesis gravidorum. That's excessive vomiting of pregnancy, and a person may actually have to seek treatment for the hyperemesis gravidorum, they may need, just to have IV fluids, actually I showed that too soon, let me go back. They may actually have to have IV fluids to replace their loss of the water in their body. Not a lot of medications are going to be used to help a person to stop vomiting during pregnancy because of that problem with the medications that a patient takes are very likely to affect the baby that they're carrying. Okay, that's hyperemesis gravidorum, that the patient's going to be treated for dehydration and to try to get their electrolytes back in balance. I want to talk about spontaneous abortion. And some people may just associate the word abortion with the elective abortions that people choose to have performed. The spontaneous abortion is what we commonly call a miscarriage. Spontaneous abortion is a miscarriage. This is the naturally occurring loss of a fetus before the 20th week of pregnancy. Usually results from some genetic abnormality. The person may have excessive bleeding and may result in low blood pressure, and certainly they may need to be hospitalized. A D&C is usually performed, which is a dilation and curettage to clean out the contents of the uterus, to remove any tissue that may be remaining after the spontaneous abortion. There are certain definitions and time periods to consider when we are documenting spontaneous abortions. Termination, it's spontaneous termination of pregnancy before fetal viability. Fetal viability, that's the fetus being able to live on its own outside the uterus. The baby actually has a chance if the pregnancy has gone over 20 weeks. The fetus may have a chance if they're over 500 grams. But less than that, they don't have a chance. And certainly, the premature, preterm labor is really considered something else after 20 weeks. And I'll get into those details in just a minute. But the spontaneous abortion, or even elective abortion, the pregnancy is terminated before fetal viability, before the fetus even weighs 500 grams, or before 20 weeks gestation. There are 3 clinical categories of spontaneous abortion. The threatened abortion. Now, threatened abortion, really the person has not passed any tissue and they have not lost the fetus. They're receiving treatment before they lose. They're having vaginal bleeding, cramping, but the cervix is still closed and they're getting treatment before they lose the fetus. In complete abortion, the cervix actually opens and some of the products of conception are passed, and the person's going to need dilation and curettage to remove the additional products of conception. The missed abortion, the fetus dies, but it's actually retained in the uterus for 6 weeks or longer. Now that's not so common these days because of the use of the sonograms. It's not likely that a patient's going to actually still carry the fetus for that number of weeks, because they should be receiving good prenatal care, and with the use of ultrasounds, this should be diagnosed earlier. Okay, some of the other conditions of pregnancy. Ectopic pregnancy is when the fertilized egg has implanted itself somewhere outside the uterus. The picture on the PowerPoint slide actually shows a pregnancy, that fertilized egg implanted itself outside the ovary. Now, the only normal place for a fertilized ovum is inside the uterus. Sometimes these fertilized eggs will end up in the fallopian tube. In fact, the fallopian tube is the most common site of an ectopic pregnancy. You've probably heard of tubal pregnancies. That fertilized egg can make its way all the way outside of the reproductive organs and just be out in the peritoneum. But these eggs are not going to grow to be fetuses out there. The woman with the positive pregnancy test and pelvic pain, they're going to need to have a sonogram and other tests to decide if they may have an ectopic pregnancy. But there are also cases where they don't have any pain at all. Those ultrasounds are so very important. A lot of times if a person has an ectopic pregnancy, they'll begin cramping and bleeding and actually have a spontaneous abortion. They'll have a miscarriage of that ectopic pregnancy. There's questions about the cause of ectopic pregnancies, but a lot of questions out there and unanswered. The treatment of the ectopic depends on a lot of different factors. If it's an unruptured ectopic pregnancy, there are medications that can be given that will cause the placenta to actually die and the products to be reabsorbed by the body. Also, laparoscopic surgery can be done to remove that fertilized egg. The tubal pregnancy, the ectopic pregnancy developing the fallopian tube, if that pregnancy grows there long enough and large enough, it may rupture the tube, and that may cause the person to not be able to get pregnant again because of the ruptured tube. Of course, that's only on one side, and the person does have fallopian tubes and ovaries on both sides. So a lot of times the person will have to have surgery associated with the ectopic pregnancy, especially if there is rupture of the ectopic pregnancy and hemorrhaging there. Okay, looking at premature labor. Premature labor, contractions leading to cervical change occurring before 37 completed weeks of gestation, before 37 completed weeks of pregnancy. If a person has a spontaneous abortion, a miscarriage, before 20 weeks, it's called a spontaneous abortion. Anything after 20 weeks, 21 weeks to 37 weeks, is considered preterm labor. And then anything after 37 weeks, then we're into the normal gestation and the normal time to deliver. There's many different reasons for the person to have premature labor: maternal infection, uterine abnormalities, fibroids. A person that has had earlier preterm labor is likely to have preterm labor again. And then there's other possible contributing factors to premature labor, like the mother smoking and being under extreme stress. There's so many wonderful things can be done now if the babies are born prematurely. Certainly the doctors are going to do all they can to keep the person from delivering, even though they may be in premature labor. There are medications that can be given to try to manage the preterm labor and the preterm contractions, and the patient may be placed on bed rest. There's also, if it's inevitable that the baby's going to be born prematurely, there's also injections that can be given to try to help the baby's lungs to develop faster if it's just inevitable that they will be born early. The outcome for the baby depends on its age, depends on its weight, if there was any infection present, birth defects. Okay, that's ectopic pregnancy and premature labor. And there's a good enrichment section there on fetal movement, being an indicator of fetal well-being. There's actually charts that expectant mothers may keep to show how often the baby's kicking or moving. We need to look at toxemia of pregnancy now. Toxemia of pregnancy is also referred to as high blood pressure of pregnancy, pregnancy-induced hypertension. Toxemia of pregnancy, medical term is eclampsia. And the full-blown eclampsia, the person will have convulsions. They may even go into a coma. It occurs anytime between the 20th week of pregnancy and the end of the first week postpartum. The postpartum period's after delivery of the baby. So a person can suffer from eclampsia anywhere from the 20th week till 1 week after delivery. Develops in 1 out of every 200 patients with preeclampsia, usually fatal if untreated. Etiology is not known. Now, the person that's going to develop eclampsia has signs and symptoms of preeclampsia first. And if they receive the kind of treatment that they should, then they will not go on to develop the eclampsia. That's why I say that the good prenatal care is so important, because it monitors the person's blood pressure. It monitors their weight gain. The preeclampsia is called pregnancy-induced hypertension. Obviously, the person's going to have high blood pressure. They'll have symptoms of headaches and dizziness and maybe even spots before their eyes. Protein will show up in the urine, and these are things that can be detected on prenatal visits and on the monitoring there. So preeclampsia can be treated, can be managed with the patient on bed rest and receiving treatment to reduce their blood pressure. It may be necessary that when a person's in preeclampsia that they will have induction of labor and maybe even a C-section. Then again, if the preeclampsia can be managed, then the true eclampsia can be prevented. Okay, next under placental abnormalities, I want you to look at the normal. These look like really big children in here, don't they, inside the uterus? Anyway, that's the fetus. Look like very full term there, maybe even 2 or 3 years old. Sorry about that. They just look really big. You can see the normal presentation for a baby when it's time for the baby to be born is that they should be head first, ready to come out through the vagina. The normal placenta is implanted in the upper area of the uterus. And the placenta is what the umbilical cord is attached to, which is attached according to the baby at the side of the umbilicus, the navel there. In abrupt shell placenta, the placenta separates from the uterine wall too early. And with that separation, there's going to be much bleeding there. The mother's going to be hemorrhaging. This is an indication that the mother needs to have a cesarean section. They've got to have treatment, and the treatment is going to be hopefully that the baby is mature enough that it can survive on the outside. In very mild cases, very little hemorrhaging there. The patient could have vaginal delivery, but they need to have the operating room ready that if the increase in the hemorrhaging may become dangerous for the mother. Prognosis depends on the degree of the abruption there, the degree of the separation, and the gestational age of the delivery. Usually if that fetus is beyond 34 weeks, there'll be really good outcome there, excellent outcome. Okay, now I want you to look at another condition, the placenta previa. In placenta previa, the placenta is implanted at the lower part of the uterus, and the placenta itself will block the baby's head from getting through the vagina. Look at placenta previa. The placenta covers the opening to the cervix, and the baby can't get through without breaking through the placenta. This can be detected on sonograms, and therefore the person could have a planned cesarean section. So you see normal presentation here, and I want you to look in your book under enrichment, the usual and unusual presentations. I teach in health information technology, and we teach medical coders, and a very important part of assigning medical codes for pregnancy cases is documentation of presentation. So I want you to look in the book and maybe mark this part of the book if you're going to be a medical coder, to be able to realize that the baby should be presenting head first. That's presentation. It's a problem if they're presenting feet first, or buttocks first, or even with their brow coming out first, or transverse. Transverse, you know that person's going to have a C-section. That baby can't come out sideways. If the babies are delivered vaginally when they're in abnormal presentation, the mother could receive injuries or the baby could receive injuries. So those are all indications to perform C-sections. Really good enrichment on the next page about the multiple pregnancies and showing how the identical twins actually share the same placenta versus the fraternal twins that have two different placentas. Okay, I want you to look at hydatidiform mole. This is a molar pregnancy. This is not really a pregnancy, but the person's levels of the human chorionic gonadotropin, which is an indicator of pregnancy, are elevated. The pregnant person will produce this hormone, HCG. They produce a large amount of it. And in molar pregnancy, the person will have high levels of HCG, and they may even have a increase in the size of their abdomen as if they might be pregnant, but there's no fetus present. Again, the person's probably going to have some menstrual bleeding. I didn't mean menstrual bleeding because they're pregnant. It's not menstrual, but some abnormal bleeding or what's referred to as spotting, which could indicate molar pregnancy. The other way this will be diagnosed is by ultrasounds, when ultrasounds are performed early. Again, the good prenatal care being so important. Treatments, dilation of the cervix, and curettage to remove the contents of the uterus. It's not really a pregnancy, even though it's called molar pregnancy. Okay, the next section of the chapter deals with conditions of the breast. The breast is considered to be an accessory organ of reproduction. The fibrocystic disease of the breast, also called mammary dysplasia or cystic disease of the breast, is benign, which means it's not cancerous. It's very common. In fibrocystic disease, the person will have lumps and cysts. Either they could have just one, or it could be multiple, more likely to be multiple. The breasts are going to be tender on palpation, and they become more tender when they're in the premenstrual time, just right before they start menstruating. Etiology is unknown. Cystic disease is the most common disease of female breast, usually occurring in the age from 30 to 50, and seems to be related to hormone variation. Biopsies may be needed to be performed just to be sure that this is the benign condition and not a cancerous condition. And then no specific treatment is recognized as being helpful, though some doctors will recommend that the patients will reduce their caffeine intake, and it may help with the symptoms. Next is mastitis, which is inflammation of the breast, and this is a condition that's usually going to occur while the person is in the postpartum period, either while they're breastfeeding or not, their breasts become inflamed because of a bacterial infection there. Very painful condition. If they are breastfeeding, they have to stop breastfeeding because it's so painful. Antibiotics may be necessary, depending on the cause there. Heat may be applied to the area. Palliative care with just rest and analgesias. And of course, if the patient's going to receive analgesics, they're not going to be breastfeeding anyway, because they're going to have to stop with this mastitis. Extremely painful breast. And then fibroadenoma. This is another very common benign tumor of the breast. Fibrocystic disease is actually more common, but when it's a true tumor formation, it's referred to as fibroadenoma if it's a benign tumor. And then the procedure would be removal, or at least a biopsy. Treatment of the benign tumor is just removal of the lump itself. The female patient in her late teens or early 20s is more likely to have the fibroadenoma than an older woman. Okay, cancer of the breast, last condition to describe here in this chapter. Adenocarcinoma of the breast is the most common breast malignancy. It occurs more often in women who have had no children and in women with a family history of breast cancer. But it can occur in any woman at any time. It's just more likely to occur in people who have a family history of breast cancer. So important to perform self-breast exams at least monthly. It's so important to identify the lump before it grows too large, before it's had a chance to invade other tissue and metastasize to other areas. Mammography is so important, and mammography can be performed according to a particular schedule set by insurance companies or set by the physician according to the woman's age. The signs and symptoms of breast cancer: a lump, swelling, or tenderness of the breast, irritation or dimpling of the breast skin, and sometimes pain. Pain usually comes later. You don't want to wait till it hurts to have some evaluation of any lump found in the breast. Surgery or the treatment for breast cancer varies from just having a lumpectomy, just removal of the lump if it's in very early stages, to a simple mastectomy, which is just removal of the breast, or in the later stages the patient may need a radical mastectomy, which would involve removal of the breast and surrounding tissues and even muscles and lymph nodes in the area. All women are at risk for breast cancer. One in every 9 women will actually develop the disease. I just can't say enough about the early detection, about the self-exams of the breast to identify the nodules or the tumors when they're very small and before they've had a chance to metastasize. And then again, those mammograms that need to be performed on a regular basis after a certain age. Even after the person has had a mastectomy with removal of breast if necessary, they may actually have to have chemotherapy as a follow-up. In fact, in many cases, they do have to have follow-up chemotherapy. This concludes Chapter 12.